Good morning, students. Do anybody present? Good morning. Okay. Arterial hypertension. Если никого нет, мне говорить или что? Пошли все. Okay. Arterial hypertension. Hypertension is defined as systolic blood pressure of 140 millimeter Hg or greater, diastolic blood pressure of 90 millimeter Hg or greater, or taking antihypertensive medication. This is classification of office blood pressure and definitions of hypertensive grade. We can see category optimal, normal, high normal, grade 1 hypertension, grade 2, grade 3, and isolated systolic hypertension. And we can see levels of blood pressure in this category. Isolated systolic hypertension is graded 1, 2, or 3 according to systolic blood pressure values in the ranges indicated. The same classification is used for all ages from 16 years. Essential arterial hypertension, this is primary hypertension or hypertonic disease, is characterized by the increased level of BP with no specific cause can be identified. In secondary symptomatic arterial hypertension, a specific cause for blood pressure elevated can be revealed. Blood pressure measurement divided into office blood pressure measurement, home blood pressure monitoring, and ambulatory blood pressure monitoring. Office blood pressure measurement. The patient should be seated comfortably in a quiet environment for 5 minutes before beginning BP measurements. 3 BP measurements should be recorded, 1 2 minute apart, and additional measurements only if the first two readings differ by more than 10 mm hierarchical. BP is recorded as the average of the last two BP readings. Additional measurements may have to be performed in patients with unstable BP values due to arrhythmias, such as in patients with atrial fibrillation, in whom manual auscultatory methods should be used as most automated devices have not been validated for BP measurement in patients with atrial fibrillation. Office blood pressure measurement, this is a continuation. Use a standard bladder cuff, 12-13 centimeter wide and 35 centimeter long for most patients, but have larger and smaller cuffs available for larger arm circumference more than 32 centimeter and thinning arms respectively. The cuff should be positioned at the level of the heart with the back and arm supported to avoid muscle contraction and asymmetric exercise-dependent increases in BP. When using auscultatory methods, use phase 1 and 5, sudden reduction and disappearance, Korotkov sounds to identify systolic BP and diastolic BP respectively. Measure BP in both arms at the first visit to detect possible between-arm differences. Use the arm with the higher value as the reference. Measure BP 1 and 3 minutes after standing from a seat position. In all patients at the first measurement to exclude orthostatic hypertension. Lying and standing BP measurement should also be considered in subsequent visits in older people, people with diabetes, and people with other conditions in which orthostatic hypertension may frequently occur. Record heart rate and use pulse palpation to exclude arrhythmia. Clinical indications for home blood pressure monitoring or ambulatory blood pressure monitoring. Condition in which white coat hypertension is more common, grade 1 hypertension on office BP measurement. Marked office BP elevation without hypertension mediated organ damage. Conditions in which masked hypertension is more common. For example, high normal office BP. Normal office BP in individuals with hypertension-mediated organ damage or at high total cardiovascular risk. Postural and postprandial hypertension in untreated and treated patients. Elevation of resistant hypertension. Elevation of BP control, especially in treated high-risk patients. Exaggerated BP response to exercise. Considerable variability of the office BP. Evaluating symptoms consistent with hypertension during treatment. White coat hypertension refers to the untreated condition in which BP is elevated in the office, but is normal when measured by ambulatory blood pressure monitoring, home blood pressure monitoring, or both. Conversely, masked hypertension refers to untreated patient in whom the BP is normal in the office but elevated when measured by home and ambulatory blood pressure monitoring. Specific indications for ABPM rather than HBPM. Assessment of nocturnal BP values and dipping status. For example, suspicion of nocturnal hypertension, such as in sleep apnea, chronic kidney disease, diabetes, endocrine hypertension, or autonomic dysfunction. Definition of hypertension according to office, ambulatory, and home pressure level, blood pressure level. We can see a category and systolic blood pressure and diastolic blood pressure. Hypertension in office BP, it's 140 and more, diastolic 90 and more. For ambulatory BP, we can see difference in daytime, nighttime, and 24 means, hour means. Daytime, it can be systolic more than 135, in nighttime 120, and 24 hour means 130. For home BP mean, it can be 135 and more. For diastolic, this level should be 85, 70, 80, and 85. This is a diagram of ambulatory blood pressure monitoring. We can see red color columns. This is the measurement of BP, and we can see on vertical line, this is BP, and horizontal line, this is time. Screening and diagnosis of hypertension. If patient have optimal BP, it's less than 120 to 80, we should repeat BP at least every 5 years. If normal BP 120 to 129, and diastolic 80 to 84, repeat BP at least every 3 years. High normal BP, repeat BP at least annually. If consider masked hypertension, we should do a BPM or HBPM. If hypertension present, we can use either to confirm diagnosis, repeated visits for office BP measurement, or out of office BP measurement, ABPM and HBPM. This is key information to be collected in personal and family medical history. It can be risk factors, family and personal history of hypertension, cardiovascular disease, stroke, and renal disease. Family and personal history of associated risk factor. For example, familial hypercholesterolemia, smoking history, dietary history, and salt intake, alcohol consumption, a lack of physical exercise, sedentary lifestyle, history of erectile dysfunction, sleep history, snoring, sleep apnea, information also from partner, previous hypertension in pregnancy, preeclampsia. History and symptoms of hypertensive mediated organ damages, cardiovascular disease, stroke, and renal disease. Brain and eyes, headache, vertigo, syncope, impaired vision, transitory ischemic attack, sensory motor deficit, stroke, carotid revascularization, cognitive impairment, dementia in the elderly. Heart, chest pain, shortness of breath, edema, myocardial infarction, coronary revascularization, syncope, history of palpitation, arrhythmias, especially atrial fibrillation, heart failure. Kidney, thirst, polyuria, nocturia, hematuria, urinary tract infection. Peripheral arteries, cold extremities, intermittent claudication, pain-free walking distance, pain at rest, peripheral revascularization. Patient or family history of chronic kidney disease, for example, polycystic kidney disease. History of possible secondary hypertension. Young onset of grade 2 and 3 hypertension, less than 40 years, or sudden development of hypertension or rapidly worsening BP in older patient. History of renal urinary tract disease, recreational drug, substance abuse, concurrent therapies, corticosteroids, nasal vasoconstrictor, chemotherapy, yohimbine, and liquorice. Repetitive episodes of sweating, headache, anxiety, or palpitation, suggestive of pheochromocytoma. History of spontaneous or diuretic provoked hypokalemia, episodes of muscle weakness and tetany, hyperaldosteronism. Symptoms suggestive of thyroid disease of hyperparathyroidism. History of the current pregnancy and oral contraceptive use. History of sleep apnea. And antihypertensive drug treatment. Current path antihypertensive medication, including effectiveness and tolerance to previous medication and adherence to therapy. Key steps in physical examination. Body habitus, weight and height measured on a calibrated scale with calculation of body mass index. Waist circumference. Signs of hypertensive mediated organ damage. Neurological examination and cognitive status. Fundoscopic examination for hypertensive retinopathy. Palpation and auscultation of heart and carotid arteries. Palpation of peripheral arteries. Comparison of BP in both arms at least once. Skin inspection. Cave outline patches of neurofibromatosis. This is in pheochromocytoma. Kidney palpation for sign of renal enlargement in polycystic kidney disease. Auscultation of heart and renal arteries for murmurs or bruits indicative of aortic coarctation or renovascular hypertension. Comparison of radial with femoral pulse to detect radiofemoral delay in aortic coarctation. Signs of Cushing disease or acromegaly. Signs of thyroid disease. What routine laboratory test you should do? Hemoglobin or hematocrit, fasting blood glucose and glycated hemoglobin. Blood lipids, total cholesterol, low density lipids, cholesterol, and high density cholesterol, blood triglycerides, blood potassium and sodium, uric acid, blood creatinine and glomerular filtration rate, blood liver functional test, urine analysis, microscopic examination, urinary protein by dipstick test, or ideally albumin creatinine ratio, and 12-lead ECG. And on this ECG, we can see signs of hypertrophy of left ventricle. High R in V5, V6, and deep S in V1, V2. Assessment of hypertension-mediated organ damage. By basic screening test. For this, this is for test on this page. 12-lead ECG. Indication is screen for left ventricle hypertrophy and other possible cardiac abnormality, and to document heart rate and cardiac rhythm. Urine albumin creatinine ratio to detect elevation in albumin excretion, indicative of possible renal disease. Blood creatinine and glomerular filtration rate to detect possible renal disease. Fundoscopy to detect hypertensive retinopathy, especially in patients with grade 2 or 3 hypertension. This is more detailed screening. Echocardiography to evaluate cardiac structure and function when this information will influence treatment decision. Carotid ultrasound to determine the presence of carotid plaque or stenosis, particularly in patients with cerebrovascular disease or vascular disease elsewhere. Abdominal ultrasound and Doppler studies to evaluate renal signs and structure and exclude renal tract obstruction. Evaluate abdominal aorta for evidence of aneurysmal dilatation and vascular disease. Examine adrenal gland for evidence of adenoma or pheochromocytoma. CT or MRI preferred to detail information. C-section, renal artery Doppler study to screen for the presence of renovascular disease, especially the presence of asymmetric renal size. Pulse wave velocity, an index of aortic stiffness and underlying atherosclerosis. Ankle brachial index, screen to evidence of lower extremity artery disease. Cognitive function testing to evaluate cognition in patients with symptoms suggestive of cognitive impairment. and brain imaging to evaluate the presence of ischemic or hemorrhagic brain injury, especially in patients with a history of cerebrovascular disease or cognitive decline. These are grounds in hypertension. We can see 4 grades. First grade, mild narrowing of the retinal arteries relative to the veins. Second, increased light moderate sclerosis with increased light reflex and compression of veins at crossings. Grade 3, edema, exudates, and hemorrhages. Sclerotic and markedly spastic silver wire arteries. Grade 4, papillary edema or shocked disc, extensive hemorrhages, and exudates. On this ultrasound examination of heart, we can see signs of hypertrophy of left ventricle. What is causes of secondary hypertension? Renal causes, parenchymal, renovascular, and others. Renal parenchymal arterial hypertension can be in chronic glomerulonephritis, chronic pyelonephritis, diabetic nephropathy, amyloidosis, and polycystic kidney. Renovascular hypertension. This is 12% of resistant hypertension, 30% of malignant hypertension. Atherosclerosis as a cause in 2/3 cases. More frequent onset in middle age and older males. Renal artery fibromuscular dysplasia in 1 to 3 cases, 1/3 cases. More frequent in young females. We can see dilated renal artery and then stenosis. In this case, we can see signs of fibromuscular dysplasia. What? Neck-like shaped renal artery contour. Other causes of secondary hypertension, endocrine. It can be pheochromocytoma, primary aldosteronism, Cushing syndrome, hyperthyroidism, hyperparathyroidism, and acromegaly. Pheochromocytoma, in more than 80% of cases, solitary benign chromophene tissue adrenal gland tumor. 10% arises out with the adrenal gland, 10% are malignant, 10% are bilateral. Tumor usually secrete norepinephrine, may produce either paroxysmal or persistent hypertension. The attacks are associated with the sudden onset of bilateral headache and with perspiration, palpitation, and pallor, features often regarded as neurotic. Diagnosis: excessive excretion of the catecholamine metabolite vanillyl mandelic acid in the urine. Urine and plasma catecholamine levels, CT or MRI to localize tumor. This is pheochromocytoma on CT scan. Primary aldosteronism, adrenal corticoadenoma, Conn's syndrome in 60% of cases. Bilateral adrenal cortical hyperplasia in 40% of cases. Occurs most often in young and middle-aged females. The symptoms and signs are related to sodium retention, hypokalemia, and hypertension. Predominant complaints are muscle weakness, headache, thirst, and polyuria. Hypokalemia, excessive urinary potassium loss, elevated plasma and urine aldosterone level, suppressive renin level. Metabolic alkalosis and low serum chloride level, CT or MRI. This is Conn's syndrome, left adrenal adenoma. Computed tomography of the adrenals in 3 patients with primary aldosteronism. Note the moderate hypertrophy of both adrenal glands. In A case, presence of the left hypodense nodular row. In B, with a thin right adrenal gland, and the presence of bilateral nodulus rows in C. Cushing's syndrome is a constellation of clinical abnormality caused by chronic high blood level of cortisol or related corticosteroids. It usually results from pituitary adenoma, adrenal adenoma or carcinoma, and therapeutic administration of corticosteroids. Cushing disease is Cushing syndrome that results from excess pituitary production of adrenocorticotropic hormone, generally secondary. Main clinical manifestation: moon face with splenic appearance, truncal obesity with prominent supraclavicular and dorsal cervical fat pads, buffalo hump, usually very slender distal extremities and fingers. Purple stria may appear in the abdomen, easy bruising, and hypertension. In this patient with Cushing syndrome, findings include facial rounding, plethora of the cheeks, supraclavicular fats, and stria. On diagnosis: urinary free cortisol level, dexamethasone suppression test, midnight serum or salivary cortisol level, plasma adrenocorticotropic hormone level, if detectable, provocative testing, and imaging: MRI, CT, positron emission tomography scanning. Hyperthyroidism, thyrotoxicosis. Hyperthyroidism is characterized by hypermetabolism and elevated serum levels of 3 thyroid hormones. Symptoms include tachycardia, fatigue, weight loss, nervousness, tremor, exophthalmos. This is exophthalmos in thyrotoxicosis. The next cause of secondary hypertension is neurogenic, increased intracranial pressure and hypothalamic syndrome. Cardiovascular hemodynamic, coarctation of aorta, atherosclerosis of aorta, complete AV block, aortic regurgitation, and erythemia or polycythemia vera. Coarctation of aorta, this is a congenital condition associated with a narrowing of the lumen of the aorta just beyond the origin of left subclavian artery. Coarctation prominent arterial pulsation may be visible in the suprasternal notch and carotid arteries. Systolic murmur with the maximum in the interscapular area. Systolic blood pressure difference between the upper and lower extremities. Femoral pulse becomes weaker. On X-ray, we can see notching of the inferior margin of the ribs by tortuous intercostal arteries acting as collaterals. We can see MRI and angiogram of aorta with narrowing. And the last causes, miscellaneous. Drug, substance-induced alcohol abusing, lead poison, pregnancy, hypercalcemia, and obstructive sleep apnea. Medications and other substances what may increase BP. Oral contraceptive pill, diet pill, for example, phenylpropanolamine, sibutramine, nasal decongestants, stimulant agents like amphetamine, cocaine, ecstasy, and other substances. Liquorize, chronic excessive liquorize use mimic hyperaldosteronism. Immunosuppressive medication like cyclosporin A, tacrolimus, rapamycin, and steroids, corticosteroids, for example, hydrocortisone, prednisone, all steroids. Anti-angiogenic cancer therapies like bevacizumab, sunitinib, and sorafenib. Other drugs and substances, anabolic steroids, erythropoietin, non-steroidal anti-inflammatory drugs, and herbal remedies. Incidence and typical cause of secondary hypertension according to age. In young children less than 12 years, the percent of patient with underlying cause, so with secondary hypertension, is 70-85. It can be renal parenchymal disease, coarctation of aorta, monogenic disorders. Adolescents, it can be 10-15%. Renal parenchymal disease, coarctation of aorta, and monogenic disorders. Young adults till 45-10%, renal parenchymal disease, fibromuscular dysplasia, especially in women, and undiagnosed monogenic disorders. Middle-aged adults, 41-65 years. This is primary aldosteronism, obstructive sleep apnea, Cushing syndrome, pheochromocytoma, renal parenchymal disease, and arteriosclerotic renovascular disease. And older adults, 5-10%, atherosclerotic renovascular disease, renal parenchymal disease, and thyroid disease. It is impractical to screen all hypertensive patients for secondary causes of hypertension. Patient characteristics that should rise to suspicion of secondary hypertension. Young patient with grade 2 hypertension or onset of any grade of hypertension in childhood. Acute worsening hypertension in patients with previously documented chronically stable normotension. Resistant hypertension, severe hypertension of hypertension emergency, presence of extensive hypertensive mediated organ damage, clinical biochemical features suggestive on endocrine causes of hypertension or chronic kidney disease, clinical features suggestive for obstructive sleep apnea, and symptoms suggestive of pheochromocytoma and family history or pheochromocytoma. Treatment of arterial hypertension. In hypertensive patients, the primary goal of treatment is to achieve maximum reduction in the long-term total risk of cardiovascular disease. This requires treatment of the rise BP per se as well as of all associated reversible risk factors. BP lowering treatment should be offered if systolic BP is more than 140 and diastolic is 90 and more. Patient over 80 years should be offered BP lowering treatment if their systolic BP is more than 160. For patients 65-80 years, BP lowering treatment should be offered at a systolic BP 140-159. Office BP treatment targets in hypertensive patients. BP should be reduced at least below 140 to 90 mm Hg and to 130 to 80 mm Hg or lower, if tolerated. If patient less than 65 years, it is recommended to reduce systolic BP to 120 to 129 mm Hg. In patient more than 65 years, it is recommended to reduce systolic BP to 130 to 139 and diastolic BP less than 80 mm Hg should be considered for all hypertensive patients. Factors influence cardiovascular risk of patient with hypertension. Sex, men more than women, age, smoking, total cholesterol, uric acid, diabetes, overweight, obesity, family history of premature cardiovascular disease, family of patient, parental history, or early onset hypertension, early onset menopause, sedentary lifestyle, psychosocial and social economic factors, and heart rate. This is classification of hypertensive stages. Hypertension, it can be stage 1 uncomplicated, stage 2 asymptomatic disease, and stage 3 established disease. And we can see how we determine the stage. So if no risk factor 1 to 2 or more than 3, we can see low. So risk depends on stage depends on risk factor, level of BP, and presence of hypertension mediated organ damage or disease and cardiovascular disease. So we can use this table. There are 2 well-established strategies to lower BP: lifestyle intervention and drug treatment. Initiation of blood pressure lowering treatment. If high normal BP, we use lifestyle advice and consider drug treatment in very high-risk patient with cardiovascular disease, especially coronary artery disease. In grade 1, we use immediate drug treatment in very high-risk patients with cardiovascular disease, renal disease, or hypertension-mediated disease. And in drug treatment in low moderate risk factor without cardiovascular disease and other disease after 3-6 months of lifestyle intervention if BP not controlled. In grade 2 and grade 3 hypertension, we use immediate drug treatment in all patients. Lifestyle changes. This is smoking cessation, weight reduction, reduction of excessive alcohol intake, regular physical activity, reduction of salt intake, healthy balanced diet containing vegetables, legumes, fresh fruits, low-fat dairy products, and others. 5 major classes of antihypertensive agent, thiazides and thiazide-like diuretics, calcium antagonists, ACE inhibitors, angiotensin 2 receptor blockers, and beta blockers. Combination treatment is recommended for most hypertensive patients as initial therapy. Compelling and possible contraindication to use of antihypertensive drugs. For thiazide diuretics, compelling, this is gout, possible metabolic syndrome, glucose intolerance, pregnancy, hypercalcemia, hypokalemia. In beta blockers, asthma, AV block grade 2 or 3, SA block, bradycardia, and possible peripheral artery disease, metabolic syndrome, glucose intolerance, athletes and physically active patient, and COPD. Calcium antagonists, dihydropyridines, only possible tachyarrhythmia, heart failure, pre-existing severe leg edema, and verapamil and diltiazem. This is compelling AV block and SA block grade 2 or 3, heart failure, and bradycardia. and possible constipation. ACE inhibitors compelling pregnancy, previous angionephrotic edema, hyperkalemia, potassium more than 5.5, bilateral renal artery stenosis, possible women of childbearing potential without reliable contraception, angiotensin receptor blockers, pregnancy, hyperkalemia, and bilateral renal artery stenosis, and the same possible as in inhibitors. Conditions favoring use of some antihypertensive drug versus others. For diazide diuretic, this is isolated systolic hypertension, heart failure, hypertension, and blacks. For beta blockers, this is angina pectoris, post-myocardial infarction, heart failure, tachyarrhythmias, glaucoma, pregnancy. For ACE inhibitors, heart failure, left ventricular dysfunction, post-myocardial infarction, diabetes nephropathy, non-diabetic nephropathy, left ventricular hypertrophy, carotid atherosclerosis, proteinuria, microalbuminuria, atrial fibrillation, metabolic syndrome. Angiotensin receptor antagonist. This is heart failure, post-myocardial infarction, diabetic nephropathy, proteinuria, left ventricle hypertrophy, atrial fibrillation, metabolic syndrome, and ACE-induced cough. Calcium antagonist, isolated systolic hypertension, angina pectoris, left ventricle hypertrophy, atherosclerosis, pregnancy, and hypertension in black patient. Calcium antagonist, verapamil, diltiazem, angina, atherosclerosis, supraventricular tachycardia. Diuretics, heart failure, this is anti-aldosterone diuretics, and post-myocardial infarction, and loop diuretics, and stage renal disease and heart failure. For improvement of the prognosis of an atrial hypertension, it is more important to decrease BP level in itself than character of medication which are applied for this purpose. This is core drug treatment strategy for uncomplicated hypertension. This is interesting. We can do this photo. To this regimen strategy and see this before your classes. Because this is difficult to read. For chronic, this is a strategy for hypertension and chronic kidney disease, hypertension and atrial fibrillation. Hypertensive crisis, hypertensive urgencies and emergencies. Hypertension emergencies are situations in which severe hypertension, grade 3, is associated with acute hypertension mediated organ damage, which is often life-threatening and requires immediate but careful intervention to low BP, usually with intravenous therapy. Typical presentation of hypertension emergency. Patient with malignant hypertension characterized by severe hypertension, usually grade 3, associated with fundoscopic changes, microangiopathy, and disseminated intravascular coagulation, and can be associated with encephalopathy in about 15% of cases. A patient with acute heart failure, acute deterioration in renal function, acute aortic dissection, acute myocardial ischemia, acute stroke. Patient with sudden severe hypertension due to pheochromocytoma associated with organ damage. Pregnant women with severe hypertension or preeclampsia. We can see what drugs we can use in what clinical presentation of hypertensive emergency. In malignant hypertension with or without acute renal failure, first line is labetalol and nicardipine. Hypertensive encephalopathy, labetalol, nicardipine, acute coronary event, nitroglycerin, labetalol, acute cardiogenic pulmonary edema, nitroprusside or nitroglycerin, acute with loop diuretics, acute aortic dissection, esmolol or nitroprusside in nitroglycerin or nicardipine, and eclampsia and severe preeclampsia. This is labetalol or nicardipine and magnesium sulfate. And we can see time target for BP reduction, so you can read this later. And this table for doses of these drugs, you can see this later. The term hypertensive urgency has also been used to describe severe hypertension in patients presenting to the emergency department in whom there is no clinical evidence of acute hypertension-mediated organ damage. With this patient required BP reduction. They do not usually require admission to the hospital, and BP reduction is best achieved with oral medication. Thank you for attention. This is end of our lecture. Goodbye, students.